All right, we are back. I am pleased to be sitting here with Cody Wilkinson. Cody, welcome.
Yes, thank you.
Yeah,
glad to be here.
Yeah, we're happy to have you. Thank you for you've traveled here from afar. Where are you from?
Very far, North Idaho.
North Idaho.
Yeah.
Okay. All right, so we're sitting in Eagle now. So nice. So thank you for making the trek down here.
Absolutely.
We're excited to hear from you. You are the Director of Population Health.
Director of Population Health for St. Mary's Health in Cottonwood, Idaho, and Clearwater Valley Health in Orofino.
Okay, and what is your role there?
So I'm the Director of Population Health. I oversee our population health programs. I do a lot of grant coordination and do some project management of different grant initiatives that we have.
All right.
Yeah.
So, all right. Well, we're looking forward to hearing your presentation today.
All right. Glad to be here. Thanks again.
All right, let's do it.
All right. So let me start here with the first slide. There we go. All right. So yes, like we said, my name is Cody Wilkinson. I'm Director of Population Health at Clearwater Valley Health and St. Mary's Health, two hospital systems up in North Idaho. And I am also a diagnostic medical sonographer. So I started out as an X-ray tech, CT tech, graduated from Boise State, and then went on to get some certifications as a diagnostic medical sonographer. So a lot of work in the radiology realm. I also went on and got my master's degree, do some grant coordination, project management. So one of the big reasons I like to go into my history is that I am not a doctor. I am not here to give medical advice. And my role here is mainly to talk about a project that we did up in North Idaho. I'm glad that Christopher Stock went before me because he teed up population health really well. My hope here is that I can actually talk about a specific project and implemented population health, in a real live case scenario. So next slide. The project I'm going to talk about today was funded by the Merck Foundation, and they did reimburse my employer part of my salary for me to be here. So my goal here today is to demonstrate one organization's journey, my organization's journey into an integrated population healthcare model for addressing chronic disease in a frontier setting. Anybody that's been to my neck of the woods up in North Idaho, they know that it is pretty remote and we do things a little bit different than they do in urban settings. So I hope to portray a lot of that today. And then number two, demonstrate clinical outcomes achieved throughout one specific model for addressing diabetes. So this grant initiative that we had through the Merck Foundation was specific to diabetes. And so that's what I want to dive into today. So everybody knows that diabetes is maybe not everybody knows, but diabetes is definitely a growing problem. You can look at this slide from the CDC website. Shows that in 2004, the dark areas are the highest concentration of diabetes patients in the United States. And you can see as we progress through the years, through 2016, the most recent data, that the United States map is getting darker, meaning more and more prevalence of diabetes. This is another busy slide I got from the CDC. But a couple of things I wanted to point out here, you can see that the prevalence of diabetes is growing in the United States. The diagnosis of diabetes is also going up. I'm hoping that means that we're getting better at finding people with diabetes and getting them into care. And then that third part is another part that I want to talk about. Some of the work we've been doing is finding the people who don't know that they even have diabetes and getting them the care they need, getting them ingrained in their healthcare system so we can get them the help they need. So just to narrow the scope down a little bit, that was the United States. Let's narrow it down to Idaho a little bit. People with type 2 diabetes in Idaho, about 133,000. Pre-diabetics in Idaho, about almost 500,000. So definitely a problem we see here in Idaho. And just one of the side note on the impact that diabetes is having, you can see that with diabetes, people have medical expenses approximately 2.3 times higher than those that don't. So definitely a growing problem in more ways than one that we are actually seeing throughout our organizations. And this is one of my favorite quotes. I went to a talk many years ago, listened to Dr. Ted Epperly. This is one of the quotes that he had up there, and it really stuck with me, is that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So what this is saying is, healthcare systems are getting real good at physical. People come in with a broken bone. We can fix that broken bone. People come in with a certain disease, certain chronic conditions, certain medical, whatever. We're getting pretty good at finding out. Science is getting pretty good at helping us, take care of those folks. Mental, that includes behavioral health, a lot of social work. It's definitely growing in Idaho, definitely increased emphasis on that. The social piece is the one that just recently has been coming to the forefront with social determinants of health and different things. So this isn't new. You can see the World Health Organization put this out in 1948 as part of their preamble to their constitution. And it's been around for a while, but social health being tackled in the realm of healthcare inside of that service offering within healthcare is kind of a new concept. So, and you can see not tackling the social determinants of health. Let me go back to that real quick. Oh, the back button works. Not tackling those social needs, those social determinants can and is playing a factor. So what this tells me is you need to have a system, you need to have an approach that addresses all three of these. One of the reasons that I think we haven't been knocking this out of the park, or why the prevalence or why the issues seem to get worse, is that a lot of the money you could see in that first slide, and this is an older slide, and there's a lot of iterations of this different infograph out there. You can see in the first one, 50% of our health, what makes us healthy, comes from our health behaviors, 20 from environment. And you can see the red at the top, access to care, is only 10%, but we spend 88% on that 10% of what makes us healthy, and 4% on our healthy behaviors. So the where we're spending the financial dollars and where we can best make impact aren't really matching up. So the infograph on the right, you can see that it takes many things: healthcare down on the bottom, housing, transportation, food, financial, a lot of things now we're coming to find are playing a factor in these, in your overall health. So we started in the United States. We went down to Idaho. This is my neck of the woods. You can see I've kind of zoomed out here. Clearwater, Lewis, Idaho County. That's our service area. It's a huge service area. We have 2 hospitals. One's in Orofino, one's in Cottonwood, and then we have 8 different clinics spread throughout. I hope some of these names of towns are familiar to most of you. But Craigmont, Nez Perce, Kamei, Orofino, Pierce, satellite clinic in Elk City. So we're really spread out. It's a 28,000 square mile area, about the size of, they tell me it's about the size of Massachusetts, but if you look down on the bottom of the slide here, you can see 2.5 people per square mile. I think the definition of a frontier area is less than 7. Don't quote me on that. I think people have told me that, but we're at about 2.5 people per square mile. And in this whole service area, 3-county area, last I checked, we have 2 stoplights. So one of the challenges that we're coming up with, or that we're constantly faced with, is how do we reach all these people when you have only 2.5, 3 people per square mile? So that's a lot of traveling. That's a lot of getting out to where the folks are at and actually providing the care and overcoming those geographical barriers. So we were fortunate about 5 years ago to be awarded a Merck Foundation grant. There was 8 grantees across the United States, and it was a multi-million-dollar initiative that aim to build sustainable partnerships to address the medical and social factors that influence health. This is a diabetes grant, so it was geared towards diabetes. So building those sustainable partnerships. I remember when I went out to Chicago, I flew out to Chicago for my first shot at this opportunity to talk about this grant. We met with the University of Chicago, who was the programmatic office for this grant. And they had a speaker there from the food bank repository in Chicago. And one of the things that really hit home, and that I thought about the whole flight home from Chicago in the 3 different connections it took, was, man, we're going to have to feed people healthy food. We're going to have to not only change what they eat, but we're going to have to help them find these healthy foods to eat and healthy, sustainable, make sure there's always food on their table. Luckily, throughout the last 5 years, we've built some great partnerships. One of them is with the Idaho Food Bank, phenomenal partner. We've done a lot of work with them. It made us realize that we're not at this alone. Healthcare, they think we're in charge of healthcare. We have to do this. We have to figure out how to make this population healthy. Well, you don't. There's so many partners out there. It's great. You find the right partners in your communities, and it's just amazing. Redesign the healthcare system to improve diabetes care for vulnerable and underserved populations. Now, this was the aims of the grant. So redesign the healthcare system. What does that mean? Well, it's a lot about what the keynote speaker was talking about before. People present to the ER. They come in some kind of a crisis. They come in a diabetes crisis or any kind of crisis. We're really good at the physical part. We take care of them. We get them healthy. We get them all of the things they need to exit the hospital, exit the emergency room, and go back to their lives. But we send them back to that community that in the same atmosphere that got them in the hospital in the first place. Food insecurity, no transportation to get them to the pharmacies to get the medications that they need. So redesigning healthcare system in our model and in what we chose to do was have a department that worked with individuals outside of the hospital setting, a lot of it outside of the clinic setting, and provided support, outside in their communities that they live in. Improve health outcomes. Obviously, you do this much work and you have this large of an award, you want to show improved outcomes. I do have some data towards the end of this that I want to show you kind of some of the data that we've been finding. And then disseminate key findings and lessons learned. That's what I'm doing here today. Sharing just kind of what we've done, how population health looks in our organization, how it can look in rural and frontier environments. So the next slide, these are the 8 different, so you can see the star in Illinois, that's the University of Chicago. And then the other 8 different grantees across the United States. You can see us in Northern Idaho there. You can also notice if you start reading through these, all of these organizations are very big. I think Alameda County, actually, don't quote me on this, but I think the population of Alameda County rivals the population of Idaho now. That was a couple of years ago. Obviously, a lot's changed with populations, but Alameda County is a huge county. I think they have more people that were in their study that were actually in ours. So, or actually in the whole state of Idaho. So definitely interesting to work with these different organizations. We were all doing the same work. We were all looking for ways to combat diabetes in our communities and using non-conventional, I shouldn't say non-conventional, but non-traditional, come into the doctor, you prescribe a medication and those means. So our work plan, now this is our work plan for our organization. We took what the Merck Foundation had intended for this grant. We put it into our work plan. So proactively engage every diabetic or pre-diabetic patient in our catchment area, huge catchment area, remember that, who was not already seeking care for diabetes prevention and management. I'm going to talk about community health workers. That was our strategy to help reach those folks that may not be accessing care on a regular basis. Address the medical, behavioral, and social needs. It goes back to the World Health Organization preamble. we wanted to look at all three of these and see how all three of these aspects played into healthcare and how it played into combating diabetes. Develop a high functioning partnership across systems and with community organizations. I think by the end of the 5 years, I don't even know how many partners we've made throughout the whole program, but it's been pretty amazing to have a lot of partners help us with this. Healthcare does not have to do that alone. If that's one thing I can iterate here today, is that there's lots of partners out there to help us with this. And then decrease health disparities in our community through proactive strategies that identify and respond to the needs of the underserved populations. We did a real robust screening and intervening program for social determinants of health integrated into our clinics. And I have some data that we can talk about on that as well. So this slide is kind of I tried to do all of our project into one slide, and I don't know if I'm gonna do it justice, but if you look at this tall column here that starts out with diabetes self-management education, you can see a lump of 5 groups there. That's our population health team. That's the team that met with patients and actually work together on finding solutions for patients. So we can go through each one of them at a time here. Diabetes self-management education. We have an RN and a dietitian who are both trained in diabetes self-management education. Obviously provide that extra support and knowledge to help people manage the diabetes in between doctor visits and help them take control and take the initiative on their own disease management. Chronic care management. A lot of these you'll see are a repeat of what the keynote speaker was talking about. A lot of these same programs. Chronic care management, folks with chronic diseases will actually get telephonic visits from a nurse in between doctor visits. So they have that support in between doctor visits. They have questions, social needs come up, anything that comes up, they have a nurse contact within the organization that they can reach out to. And then that nurse can work within that population health team to make sure that that patient has the needs that, that all of their needs are met. Community health worker engagement. I'm going to dive into that a little bit deeper, just because it was one of the unique elements that not a lot of people, not a lot of organizations have adopted yet, but a lot are definitely working towards. And there's definitely a growing force of community health workers in the area. So they're in the state of Idaho. So it's definitely been an amazing push there. Integrated behavioral health, that plays into that, the one of those 3 pieces, the physical, mental, and social. This played into the mental behavioral piece. People need that support. One of the things I like to do when I stress out is I go have a bowl of ice cream and sit on the couch and I don't do anything. Well, maybe that's not the best coping mechanism. I'm like I said, I'm an ultrasound tech, so I'm speaking out of turn. I should not, but that's me. That's what I do. So maybe there's different methods, different ways to cope, ways to deal with different stressors that are contributing to their ability to help manage their own diseases and chronic conditions at home. Our behavioral health specialists are integrated in our clinics. They're there for warm handoffs for the providers. They're integrated with the medical team. So they're a big proponent of this project and the support that we're providing to our patients. Medical nutrition therapy, that's our registered dietitian. He also works in the group. And so any patient, and then I should add, there is a 6th one that is not necessarily a part of this group, but that we use the resources a lot. We have, she's the prescription assistance tech. So she works with, I guess she'd be kind of like that, the pharmacy tech that Chris was talking about in the first half of the program, but she'll work with folks to help them get high cost medications at low cost, no cost, depending on the programs that we can get them enrolled in. So helps them with prescription assistance. We also have benefits counselors that can help people get enrolled with insurance. Our community health workers do a lot of that too. So patients that are identified by our providers, this is provider driven, provider led, people with that are identified as having diabetes or new diagnosis or having trouble managing, they can be referred to our population health team. The population health team will work together to do whatever they can to address the needs. You can see on the right hand of the column, a lot of that entails transportation to and from appointments, to and from, if they're referred out to an endocrinologist or anybody else, we're able to help set up appointments. Housing insecurity, food, medication assistance. So we have a lot of programs that we're able to assist folks with through this model. I'm going to skip through this. There we go. So results in the field, I just want to talk about a little bit about the different things that we're finding. This model is not one that we've made up. We've done lots of research with the help of the University of Chicago, and patients engaged with interdisciplinary care team roles. When you have PCPs, social workers, community health workers, diabetic educators, all working together, you see, and the research shows, better chronic care experiences, improved self-management behaviors, improved A1C glycemic control, lowered blood pressure, controlled blood pressure, reduced ED visits, inpatient utilization, reduced healthcare costs. This is from a research that we've done. This is not necessarily stuff that we found in our program, but this is what helped guide our program that we implemented. Here's a picture of Cottonwood. You can see that it's remote. We've done some research and we have found a couple articles where it does talk about these kinds of models, integrated models happening in rural and frontier communities. We're a little bit unique and we have 2 hospitals in a huge area, and we use community health workers. So anybody's interested, I do have articles that I can share with you if you reach out to me. And this kind of just talks about our overall impact that we've had. You can see the different individuals that interact with each of our different departments, the different programs that they're able to engage with. And then I want to hone in on this touches from the community health worker. It's about the 4th from the bottom. There's about 9,000 visits there. And then if you go up a couple more, 1,500 visits, individuals screened by community health workers. They played a huge role in the last 5 years in really getting the work done and getting to those patients that need that. So if you go to this next slide, what they do, our community health worker interventions, how we design it in our frontier area is we, first couple of years, what it was finding those patients out in the communities that didn't know they necessarily had diabetes, had elevated A1Cs, different chronic conditions. So we perform a lot of screening fairs, screening events, resource fairs. We provide free A1Cs, blood pressures, PHQ, which is a depression screener. We can do a body mass index, provide fit tests, health risk assessments. That's our assessment for social determinants of health, food, housing, transportation, social isolation, those kinds of insecurities. Different community resources. Our community health workers, when we recruit them from the areas that we need them to work in. So our CAMI community health worker that works in CAMI is from CAMI, knows the resources. They know the pastors. They know the hours of the food bank. They know all of those resources that they can help guide those folks in that area, to those resources. We have 6 community health workers spread throughout that 3 counties. And then they can provide health education in the form of pamphlets, in the form of, again, connecting them to resources. Our community health workers are not medically trained, so they're connectors in our organization. They can also help people. If you go to the one-on-one visits, a provider can actually schedule a community health worker one-on-one visit with a patient. They'll do this health screening, everything up there on the first line. And then if they have medication concerns, we bring those back to the healthcare providers. We use that information, and then if they have medication concerns, we ask them if they do, and then they can go back to the providers and give them that information. Then the provider will reach out and talk to them. Home safety concerns. We work real closely with public health, District 2 Public Health, blood pressure monitoring home loaner program. So lots of different things we can do on one-on-one visits. Community workshops, they're all trained to facilitate chronic disease and chronic pain self-management classes. This includes stress management, sleep quality, appropriate exercise, nutrition, fatigue, pain, isolation, all of those things they can touch on and talk about in a group setting. Obviously, COVID has put some of those things on hold. We've had to adapt how we're doing a lot of these programs. But we've definitely been able to maintain the work that we're trying to do throughout the communities. And then the last one is community events. So resource fairs. If somebody, so really it's a screening event that we bring public health into. We have a great partner, Nimipu Health in North Idaho. They partner with a lot of our organizations. Or partner with a lot of our resource fairs. We conduct community walks where people actually get together and walk. And recently through COVID, we've had virtual walks as well. So lots of different ways to engage the community. Just some statistics here on the kinds of folks that we're able to interact with our community health workers. You can see that in the green section is the bulk of the folks that we're able to work with. They're isolated, small rural, and blue is small rural on the left. You can see we don't have an urban population. And then on the right, you can see frontier and not frontier. So you can see a majority of our folks are all within that frontier designation. You can also see the types of folks that we see at our screenings. You can look at the statistics, 89% are insured. So we're those that aren't, we're able to help connect to insurance, attend regular PCP visits, A1C is greater than 6.5. And then you can see folks that are in the OB class or hypertensive classes. So we are reaching a lot of folks that actually need the work. Here you can see some pictures of the work that we're doing. Bottom right corner, you can see Dvorak Dam. The top picture, you can see we had to do drive-through, COVID adapted for COVID. And then obviously on the prairie up there, we get a lot of snow. That doesn't stop us. So a lot of these are some of the community walks that we do. Now I want to talk about some of the data that we're actually finding through this 5-year program. It's actually pretty interesting. I do want to, a couple caveats about the data is we throw all of our population data into one set. So we didn't actually have a study set of 100 patients with diabetes that we tracked through the 5 years. We did a point in time data poll, and we were able to say all of our patients with diabetes currently, this is where we're at. So you can see we separate into 3 different categories: no population health team, minimal population health team, and then population health team intervention on the right. So not a true study data, but data set. But what we do want to iterate here is you can see different trends starting to emerge. Also keep in mind that this was through COVID and population influxes. And so there is a lot of caveats to this data, but you can start to see trends emerge. Folks so all 3 groups, you can see the A1C average go down. Even if they have no population health intervention, which means we have amazing providers and nurses doing great work. But if you look on the far right, you can see significant drops as well. And you can actually see that those drops are actually durable. They stand the test of time. 36 months across all 3 categories, you see that they start to come back up again. So that's one thing we're going to focus on, is how do we continue to engage folks past that 36-month window. Improved clinic data availability, you can see on the far right. These are folks that when we had a data set at baseline, we were able to keep getting data set throughout the 36-month period. So what this means is, no, we're not forgetting to do the data set. It's loss of engagement or, loss of touch. So patients come in for a baseline A1C, they're thrown into our data set. And then after that, they, for whatever reason, don't engage again, don't come back to the organization, don't see a provider again. So you can see on the far right that people who do have population health interventions engage longer, and stay more engaged in their health and are coming back more and more at a higher percentage than those that aren't in the population health. This you can see that we looked at blood pressure and statin use. They've all gone up evenly across the board. So that's a point that is not, that not changed to our organization. However, if you look at the A1C percentage of folks with an A1C less than 8, you can see it stays pretty static on the no population health team. But when you do minimal population health, which is 1 or 2 touches, population health intervention, which is 3 or more touches, you can see that the actual folks with an A1C less than 8 actually increases. So people are lowering their A1Cs. And then you can see that a lot of what this slide shows is the social determinants, social needs and medical needs. Social needs across the board, our patients across the board are seeing social needs is one of the things that we found. But if you look at the medical needs part, you can see that those that are being referred for a population health intervention actually are those with more chronic conditions, more hospital visits, more ER visits, and taking more medications. So we are targeting these interventions. We have been able to risk stratify these interventions to the folks that are actually needing it. Yep. So our next steps, just to slowly wrap it up here, our next steps to sustain this kind of a model is we want to continue to find ways to reach underserved populations, especially beyond that 36 months. So why are people dropping off at 30 months, 36 months? Why are we not seeing the continued durable decreases in A1Cs? Further enhance the intersection of physical, mental, and social needs. How do we continue to push that envelope? The keynote speaker before me talked about some different players, different people that you can see inside of a population health team. And I got some ideas just watching his presentation. So I think I'll definitely take some of those pieces home. Find new ways to use this data. Social determinants data especially is new to us. So it's going to be interesting to see what we can begin to do with that data. How do we continue to help the maximum amount of people that we can? Continue to develop resources and collaborate with community-based partners. I lost count of how many partners we have, but in my opinion, you can never have enough. You can never have enough people to refer to. And then finding funding solutions. This grant that we have has been phenomenal. It's got us to the point where we're at. And now it's on to the next funding source. To continue to keep these programs going, and continue to look at ways that we can capitalize on value-based care reimbursement. So Dr. Kelly McGrath, there was 5 people on our team that led this. Dr. Kelly McGrath, he's really involved in a local, state, and national level on different healthcare initiatives. But out of this project, he said, our journey to improve rural health outcomes has taught us that non-traditional elements of our care team, such as community health workers, when coupled with highly reliable traditional healthcare, may be the missing element to achieve healthcare value and equity for rural and frontier populations. We don't have all the answers, but we feel like we have some good data that's showing us that we're doing some good work. We're on our way to value-based care, to lowering the disease, diabetes disease prevalence in our communities, or at least the severity of the disease. We feel like we're on the right track. So we're just going to keep pushing, keep forging ahead, see if we can continue to broaden that. And then if you want more information, you can go to our website and just kind of see some of the cool programs that we're doing. The grant has a website, bridgingthegapdiabetes.org. There's lots of videos. I skipped over some videos today. Go watch those videos. They're actually cool. Representations of what we're doing. You can also see what the other 7 grantees are doing. So there's lots more other information there. And if anybody has any questions, you can certainly reach out to me. There's my email, there's my work phone number. I'm on LinkedIn if you just want to be friends. But feel free to reach out. And I don't know if any questions popped up, but that's all I have.
Looks like we do have some questions.
Great.
We have a question from Jennifer, who says, would you please define what types of providers fall into the community health worker category?
So our community health worker is its own category in itself. So when we hire a community health worker, it's any lay person, no medical training. Some of our community health workers are retired nurses. I think one of them is retired laboratory science. But some of them are just folks who are passionate about helping their communities. So there's no stipulation except for you need to live in the area from which you're going to serve for at least 2 years. That's kind of one of the stipulations we set. When we do hire a community health worker, we put them through the training at Idaho State University. They have a great community health worker program, training program. I've done it myself. It's a wonderful program, so you can look into that. I know there's other programs out there. That's just the one we use. So I hope I answered that question, Jennifer.
And there's also a question, what was the age range of the people in your study?
So it was folks 18 and over, anybody with diabetes.
And did you have a mean sort of average?
I'm not at the tip of my tongue, but I could, if somebody wants to reach out and learn more about that, we definitely could. The problem with our data set that we're finding is we did a point in time data poll of our diabetes patients, and then we would see how their engagement fell through that. So there was at one point when we did a data poll and then we did a subsequent data poll 6 months later, we actually had about 90 more diabetes patients in that data set, people moving into the area in paneling with a provider. And so it does skew the data set. It's not, like I said, this is not a scientific study necessarily. It just helps us see how our interventions are working in our communities. So I hope that answers that.
You talked about efforts to reach people who are pre-diabetic.
Mm-hmm.
Can you speak to that a little bit more? How that engagement works?
So our strategy is through the community health workers. Obviously, anybody that comes through anybody that comes through our organization, we're able to screen if our providers feel it necessary. This is all, like I said, provider led. If there's anybody that screens, that they're concerned about, we can engage them in our programs. All it takes is a referral from our provider. But our community health workers, through those screening events, we go to like the Idaho County Fair, we go to different organizations ask us to come out and do screenings for their employees. So, it's amazing the people you'll see the folks that come in and get screened and they're like, oh, I'm fine. I'm healthy. I don't need this. And their buddy or whoever convinces them to do it, and they come up pre-diabetic or diabetic. So our strategy is don't operate inside the walls. You can't healthcare is no longer able to operate inside the walls. You have to get out in the communities and you have to find those folks where they're at, or help overcome those geographical barriers, those social barriers, transportation and different things. The clinics are only open during, working hours. So we would try to have screenings on the weekends and in the evenings. So we try everything we can to go where the people are and give them every opportunity to get screened. I hope that answered that.
We have a couple of other people who have put appreciation into the chat, and we will make sure those comments are shared with you.
Yes, great. Yeah, and feel free to reach out to me. Like I said, you have my email, phone number. So, yeah.
All right. Cody, awesome work.
Was it?
Yes, it was
Okay,
amazing.
good.
Yes. The amount of data that you've pulled here, really granular, really impressive. So thank you from everybody at the Idaho Health Continuum Care Alliance. Thank you for your time. Thanks for traveling all the way down here. Your preparation, your presentation was awesome. We're going to take another 10-minute break. We'll be back here at 10:30 with a panel discussion about caregiving. So we're looking forward to talking to them. Cody, safe travels.
Thank you.
We'll hopefully see you soon.
Absolutely. Thanks for letting me come and tell my story.
Absolutely, man. Great stuff.
Great.